preguntas de la audiencia. Lástima, digo, la verdad es que los temas que se han discutido todos son de sumo interés. Doctora, por favor.
Buenas tardes. Mi pregunta es para la doctora García Sao. ¿Hay algún rol en los pacientes que vemos en forma externa, ambulatoria, de hacer cultivos para buscar colonización, ya que muchos de estos pacientes pues están constantemente hospitalizándose y algunos están colonizados por microorganismos multidrogoresistentes? ¿Es sí tratarlos?
Lo que pasa es que no es necesariamente el que está colonizado el que hace la infección. Hicimos ese estudio. Entonces, por ejemplo, todos nuestros pacientes hospitalizados, todos ellos, o sea, la precaución es, o sea, les hacen muestras de heces y esto para ver si están colonizados, pero no se ha visto una relación clara con el colonizado, con el que desarrolla enfermedad, entonces por lo pronto yo no lo recomendaría.
¿Y si encuentra algún paciente colonizado, le da tratamiento? No.
No.
¿Y en el contexto de un paciente para trasplante influye en la profilaxis antibiótica?
Solo si es un enfermo. Si es un enfermo, o sea, si el paciente está para trasplantarse, no se ha infectado antes, incluso me cuesta trabajo, pero no se ha infectado antes, que es muy raro que eso sea. Lo que pasa es que nosotros estamos trasplantando a MELS de 35, o sea, ya estos pacientes casi el 100% ya ha tenido peritonitis, ya ha tenido otras infecciones, pero suponiendo que están trasplantando a MELS más bajos, ya el paciente nunca ha tenido peritonitis y tiene estos criterios de Fernández, es decir, o está ictérico, o tiene un Child-Pugh más de 9, o tiene insuficiencia renal aguda o hiponatremia, en esos vale la pena que les des ofloxacina.
Gracias.
Adelante, doctor.
Buenas tardes. En relación a la hiponatremia por la terlipresina, doctor Carrillo, no sé si usted recomiende utilizar bolos o infusión en caso de un paciente que ya tenga hiponatremia.
Digo, desde el punto de vista de hiponatremia, digo, las dosis eran alrededor de 4 a 6 miligramos. No si bien es cierto es que con infusión la cantidad de efectos adversos es notablemente menor, y además la dosis es discretamente menor, pudiera ser. Sin embargo, hasta donde yo tengo entendido, no está estudiado. Yo, si lo recomiendo, lo recomendaría en infusión, pero más bien para fines de evitar efectos adversos. Pero si la recomendación es diferente, yo creo que lo más importante es tratar la enfermedad que condiciona mayor mortalidad, que sería la hemorragia varicial en ese momento.
Ok, gracias. Y para la doctora Sao, voy a hacerle una última pregunta en relación a la rifaximina como antibiótico preventivo en estos casos para evitar también resistencia.
Bueno, como le diría el doctor Bajaj, no cambia la microbiota, él va a hacer un comentario, pero los estudios son todos retrospectivos que muestran una disminución en la infección. La evidencia no es clara y de hecho la guía del europeo dice que no podemos recomendar rifaximina para prevenir infecciones. Yo creo que no sirve para esto.
Gracias.
Sí, doctor Uribe.
Yo tenía un comentario, si me lo permiten, sobre los hallazgos de hipocorticismo en cirróticos. Yo creo que el que no haya consenso terapéutico en mucho se debe a que los estudios están mal diseñados, con todo respeto. Porque no se considera cortisol total como el que regula el eje, sino la fracción libre. El protein binding de cortisol es de 30%. De manera que cuando hay hipoalbuminemia, que es muy común en los cirróticos, este equilibrio se altera y la fracción libre controla y hace que se baje la producción de cortisol. Eso explicaría por qué muchos estudios salen contradictivos, y es que conforme avanza la enfermedad, hay más hipoalbuminemia y como consecuencia hay más cortisol libre, se requieren menos niveles de cortisol libre de total para que se haga el equilibrio. A mí me gustaría preguntarle al doctor Bajaj. Doctor Bajaj, en México es a widely used ornithine aspartate. In Mexico has been perhaps 10 or 15 years in which it's available ornithine aspartate. And many people among the audience use ornithine aspartate as a treatment. What is your concept about it?
Lola or L-ornithine aspartate has been in many countries, not in mine, so I can't give you any effect on that. The other issue is with Lola, the IV Lola has much better evidence than the oral Lola. So the studies with oral Lola, there was that recent Cochrane analysis. I would urge you to read it. It didn't show that it made any benefit
beyond regular protein, the oral form only. The IV form has a lot more evidence. There was a nice Indian study with 2 centers that showed it reduced the HE episodes. There was a study obviously in Germany that started the whole thing with Dr. Gerkais. So I personally don't have any experience with that, but I can only go over what's been published.
I have a question for Dr. Bajaj. It's very provocative, the study about the fecal transplant in hepatic encephalopathy, and these patients, the patients that receive the fecal transplant receive 5 days of antibiotics. Do you believe that if the patients had received only the fecal transplant with the antibiotics, the results could be different? They were very good results even with antibiotics.
They were unexpectedly good results, this was a safety study. We didn't expect this to have any clinical benefit. And even now, it could be a type 1 error because, it's very small sample size. So the antibiotic use with ciprofloxacin, metronidazole, and amoxicillin was forced upon us by the sponsors of the people who were giving the fecal transplant, because they were very afraid that these patients were on rifaximin before. Everyone in this study was on rifaximin. They were very afraid that the rifaximin would kill these bugs. So they wanted to kill the local flora first. I have no way of answering your question, but the study that we have just completed, which is in follow-up phase, in which we're doing the placebo versus the fecal transplant capsules, we did it without antibiotics. So hopefully we'll get some results with that later. But antibiotics really should not impact hepatic encephalopathy course. If at all, it should increase the engraftment, because all the antibiotics that we use with patients who are anyway infected do not hasten the ultimate recurrence of encephalopathy. So short of rifaximin or antibiotics that are directed towards the precipitating factor, I don't really believe that contributed a whole lot, but again, I don't have any evidence apart from mine.
I have another question for Dr. Bajaj. Which is the role of the brain reserve in patients who cover hepatic encephalopathy?
And that's a good question. So brain reserve or cognitive reserve is how much brain that you actually have, or how well you have taken care of your brain over the last few years since you've got it. So people who are poor socioeconomic status, poor higher alcohol use, and people who don't have enough friends or enough social life, they tend to suffer more with little problems in their hepatic encephalopathy. So if you look at people who have been non-alcoholic, who have high socioeconomic status, good education, have been otherwise taking care of their life and their brains, and they have good social networks, if they have covert hepatic encephalopathy, the effect on the quality of life is not as much as someone who doesn't have that much brain left and doesn't have a good social network. So what it tells you that it's not just important for you to do the testing, it's also important for you to do the patient-reported outcomes. Like I was talking about health-related quality of life in hepatic encephalopathy, because that's important because you're treating patients, again, not treating tests. So each thing you have to, make it as close to your patient as possible so that they actually can follow what you want to say, what you want to do with it.
Excellent, your answer. Pues les agradecemos a todos su asistencia y a continuación seguiremos escuchando al doctor Bajaj, que lo va a presentar el doctor Francisco.
Sí, buenas. Voy a pedirles de favor entonces a quienes nos hicieron el favor de acompañarnos en esta tan interesante discusión. Doctor Bajaj, le invito a pasar al podio a desarrollar su tema de la conferencia magistral. Permítanme, para quienes no conocen al doctor Bajaj, darles una semblanza de su currícula. Él es profesor asociado de medicina en la división de gastroenterología y hepatología y nutrición en la Universidad Commonwealth de Virginia. Es profesor desde hace ya tiempo y actualmente se desempeña en ese hospital. Su entrenamiento, su formación de médico lo hizo en la India. Posteriormente migra a los Estados Unidos, donde hace su formación en medicina interna en Nueva York, y de ahí hace su entrenamiento en gastroenterología y en hepatología en Wisconsin, donde obtuvo además un grado de maestro en ciencias. El doctor Bajaj nos va a desarrollar la conferencia magistral Microbiota en enfermedades hepáticas. Doctor.
thank you. It's still me. Hopefully you've not forgotten me since the last 20 minutes. So thank you again. Thank you again for this opportunity. So what we're going to talk about is a topic that has basically taken over everything. Everything that you think about now is being blamed on the gut microbiota. Let's see how liver disease fits into that aspect. So the outline, why is it relevant to study microbial change in liver disease? What is lacking in the current therapies? We'd heard a lot about therapies, including rifaximin, etc. What are the levels of therapies that we can use in reducing the severity of liver disease that are focused on the microbiota? And last but not the least, and this is the most important point, is microbial therapy going to be enough? Is it going to be enough to change the prognosis of patients with liver disease alone without treatment of the liver disease itself? And this is where we need to focus a little bit more. Before we go any further, as we know, the microbiota has trillions and trillions of cells in our body. It's not just present in the gut. We usually think of the gut as the biggest source because it is the highest concentration of microbiota anywhere. But there are microbes present everywhere. You look at the placenta, you look at the blood, you look at the serum, you look at the lungs, you look at the skin, there are microbes present everywhere. So the more important thing to realize is we have co-developed with these microbes for millennia. We need the microbes need us. And more often the microbes work with us. When the microbes start working against us, it's usually because of our disease process, or we are feeding them wrong things, or we are doing wrong things to our body itself. The other question is it important to study which microbes are present, or is it more important to study what the microbes are doing? It is always more important to study what the microbes are doing because it's the function of the microbe that interfaces between us and the microbes itself. The third point is what do the microbes interact with? The microbes interact with each other. The microbes interact with the cell, the human host that it is, it's along with it. So if it's the gut, it interacts with the gut wall and the lymphoid tissue. And the microbes interact with non-bacterial component, such as fungi, such as the food items, such as the xenobiotics that we put in our body, and the viruses. So our microbiota analysis is very limited right now. We usually talk about what is present and absent, not what they're doing. And we usually focus only on the bacteria, and we usually focus only on the gut. That having been said, even these things are so complex that we have barely scratched the surface in liver disease. So going forward, what is the relevance of microbial change in liver disease? As was elegantly pointed out by Dr. Garcia-Tsao and many of the other speakers, this is a continuum. Most of liver disease is not cirrhosis, even though most of the microbial studies are done in patients with cirrhosis. Liver diseases, especially alcohol and non-alcoholic fatty liver, initiate microbial change independent of the liver disease. So you can have a patient with significant gut microbial change in alcohol and non-alcoholic fatty liver disease without any significant liver disease at all, because these diseases start with the gut, and this gut can actually figure out who possibly can get the liver injury. But is it okay for us to say that the gut microbes are the reason why some people get alcoholic liver disease and some people don't? The answer is no, because in this study you have healthy controls. These are alcoholic cirrhotics, alcoholic patients without liver disease, and these are alcoholic patients with liver disease. And you can see the microbial change, the Bacteroideaceae, is the same. And many other studies have been done so far showing that it is not the microbiota itself that determines who gets alcoholic liver disease and who doesn't. So again, one thing, the alcohol is what is driving that, the genetic factors are what are driving that, not just the microbiota itself. So when someone wants to not stop drinking and wants to take a probiotic instead, you tell them this is not what is going to prevent you from getting alcoholic liver disease. You have to stop drinking. What about non-alcoholic fatty liver disease? In non-alcoholic fatty liver disease, as we said, this is patients with F2 or higher. As we know, F4 is cirrhosis and F0 is normal. As the disease progresses, things get worse. But again, we don't know whether this is the chicken or the egg. Because human liver diseases takes decades to actually unfold, it is very difficult for us to control to see whether the microbes drove the liver disease or the liver disease causes the microbial change. At this point, all we know in pre-cirrhotic disease is the microbiota change along with the disease process, and at least in alcoholic liver disease, it does not really guarantee who is going to develop liver disease or not. We know, of course, once the end stage of fibrosis, the cirrhosis develops, there's a lot of change in microbiota, and microbial change, including bacterial translocation, as Dr. Garcia pointed out, is associated with systemic and intestinal inflammation and is clearly something that is very wrong in the patients with cirrhosis. So is this just because the bad bugs are growing, or is it because cirrhosis induces a change in the body that allows those bad bugs to grow? And if that is the case, why don't all the bugs in the gut go and cause SBP? Why is it only one bug? You see, everyone who has spontaneous bacterial peritonitis has E. coli, Klebsiella, Streptococcus. It's very rare to find 2 or 3 bugs. In fact, if you find 2 or 3 bugs, it is really secondary bacterial peritonitis, which is a whole. So it is not just the presence of bugs, it is a perfect confluence of the liver-associated immunosuppression that happens systemically and locally, in addition to having one virulent bug such as E. coli, which has all the bad stuff. It has the strongest endotoxin, it is able to cross the barrier, but it is only allowed to survive the passage because the lamina propria lymphocytes are not doing their job and the mesenteric lymph nodes are not actually able to do their job. So that is why it is able to cause SBP. And that is why we don't find most of the bacteroidetes and firmicutes, which make 90% of the stool microbiota, in the ascites fluid, and we find one bug only in patients with cirrhosis. So can these bacteria be used as biosensors? So looking at ecosystems. So this is a very complex ecosystem. It's not one bug, it's not 2 bugs, it's millions of bugs interacting, again, as I said, with each other, with other organisms, and the host itself. So looking at any organism or any ecosystem, you divide them into keystone organisms and indicator organisms, because you want to know, is this ecosystem functioning well or not? So for the marine ecosystem, the keystone right here is the krill, is the little plankton at the bottom of the food chain. It's seemingly very unimportant, but everything depends on it, which means this is the keystone. If this falls down, the whole arch collapses and the whole ecosystem is gone. So if you count the krill, you don't need to count the amount of whales, you don't need to count the amount of penguins. You know if there is enough krill, there is enough of the other stuff. So this indicates something that is essential and is keystone. The alternative is indicator organisms. These are things you don't want in the ecosystem. For example, if you have drinking water and you want to see if there's a contamination with sewage, what you want to do is to see if there are coliforms, again like E. coli present, which by and large means sewage. So if these things are present, means things are wrong. So ultimately what we want to do is a biosensor that combines both a keystone organism and an indicator organism, which means things that are bad and things that are good. Is this something that we can do in cirrhosis? Because it's very easy for us to know which are good bacteria. What are the good bacteria in cirrhosis? Are the good bacteria everywhere? These are Lactnospiraceae, Ruminococcaceae, and cluster 14 Clostridium. Why are these bugs important? Lacno, Rumino, and cluster 14 Clostridium? Because they make short-chain fatty acids. And we know short-chain fatty acids can be produced either by plant polysaccharides or by branch-chain amino acids. These actually are nutritive to the colonic epithelium, and they actually reduce insulin resistance to the patients. So these are very important things that we want to have. So if you look at any study of microbiota, you don't need to worry about cirrhosis. You talk about diabetes, you talk about obesity, you talk about C. difficile, you talk about Crohn's disease, you talk about other inflammatory bowel diseases. All of it means that there is an absence of these organisms. So these organisms are, as what we told, keystone organisms that indicate things are going right. So what are the indicator organisms? For us in cirrhosis is Enterobacteriaceae. Enterobacteriaceae are gram-negative rods which include Klebsiella, which include Pseudomonas, which include, which include Proteus, which include E. coli as well. So these are the things you don't want. So we came up with a ratio called the cirrhosis dysbiosis ratio, in which the good bugs are on top and the bad bugs are in the bottom. So if the good bugs are on the top and the bad bugs in the bottom, things that are good have to have a high ratio. So healthy controls had the highest ratio. Compensated outpatients were much lower. Decompensated outpatients were even lower, and infected inpatients, most of whom had SBP, were the lowest, which tells you that this works well. This is what you would expect in someone, because this is how the cirrhosis progresses. This was also stable over time, worsened with the development of the first episode of HE, and was worse in those who were subsequently hospitalized. So this is a gross oversimplification of something that is very complex, such as the microbiota composition, but it ultimately makes us bridge the gap between clinical practice and what we know scientifically, tells you that this can be used to actually predict outcomes in these patients. And how can we predict these outcomes? In patients with cirrhosis, if they have, this is a principal component analysis, each dot or triangle represents the microbial variation of one person. Okay. So in this study, they took patients who ultimately died versus those who didn't in 30 days. And this was a validation of our original study. And the reds are the ones who died, and the blues are the ones who were alive 30 days later. So here it tells you things that are clustered together are related. You can see the people who ended up dying had microbiota that were closer together than people who ended up living. And this is despite everything we did to these patients, which tells you that in patients with cirrhosis, the microbiota changes are already fixed by the time they come in, and they could determine who lives or dies. In this study, we did the salivary microbiota, not just the fecal microbiota, and we found, could the salivary dysbiosis ratio, which is the good bacteria divided by Streptococcus acei, and this tells you if something is high, again like the cirrhosis dysbiosis ratio, it's good. The microbiota are doing good. So people who were hospitalized had a lower salivary dysbiosis ratio compared to those who were not. What about brain function in these patients? How does that actually change with microbiota? It is clear that there is an association with microbiota change. The good bacteria are associated with better cognition, not only in the actual stool, but also in the colonic mucosa. This is Ruminococcus acei. As I said, Ruminococcus acei is good bacteria, and the genus is actually Faecalibacterium. For those who follow Clostridium of the Crohn's disease and ulcerative colitis, Faecalibacterium prosnitzi is now being developed as a probiotic. It indicates everything being right with the situation. So this actually was associated with good cognition in patients with cirrhosis as well. So microbial change is very relevant to patients with cirrhosis as far as their outcomes are concerned, as in serious outcomes such as death, hospitalization, and brain function. So are gut microbiota necessary for this brain dysfunction? Obviously, we don't have any germ-free humans, so the only way we can do it is animal models of germ-free cirrhosis. So this is the cerebellum, and this is the cortex. We did IL-1B and MCP1, which are inflammatory markers, and we did IBA1 and GFAP, which are markers of the microglia, which is the inflammation inside the brain, as well as GFAP, which is the glia, which is the astrocytes. So we have 4 groups of mice: conventional controls, conventional mice with cirrhosis, in which give them CCL4 for 12 weeks. Then you had germ-free controls and germ-free cirrhosis. Basically, these mice were given CCL4 in the identical conditions, except they remained germ-free. And what we found, the only mice who had inflammation in the cortex and the cerebellum were the ones who ended up being with the microbiota. And what is more relevant is the germ-free mice still had a high ammonia level. And they had a high ammonia level because the ammonia in them was being produced by the glutaminase on the brush border. The glutamine that was being taken in by the chow that the mice were eating was still having a high ammonia level. So it tells you that despite a high ammonia level, you need the gut microbiota to cause inflammation in the brain, which is the corollary for hepatic encephalopathy, which underlines that microbiota in cirrhosis are very, very important, at least for some complications. And as we said, they may be important in the prognostication of these patients, and they may also be important in diagnosing who's going to do well or not. So what are the current therapies? We know many therapies for cirrhosis are related to the microbiota. Pre-cirrhosis, probiotics have been tried, but they have been very, very poor evidence. Because remember, each strain of the probiotic is a different organism. It's a different drug. And we combine all of them together and say probiotics. You wouldn't do that for antibiotics, would you? You wouldn't combine streptomycin, the trials for streptomycin, with the trials for ciprofloxacin and say antibiotics and do a meta-analysis. But that's the same thing that happens in probiotic. All probiotics are different. But even when you combine all of them together, the evidence in NASH as well as alcoholic liver disease before cirrhosis is very, very poor, to the point that it can absolutely be negated. You cannot do anything with this. What about cirrhosis? The best evidence in cirrhosis is on hepatic encephalopathy. There's good data with VSL3 for readmission prevention, prebiotics and laxatives such as lactulose and lactitol, as well as antibiotics. So this is the study that I showed you in the prior thing about rifaximin, which clearly prevents rehospitalization and encephalopathy. But again, this is something 21% of patients, even in this highly selective trial, still had changes. What about VSL3? VSL3 reduced the time to hospitalization, but again, there are some patients who keep on getting these things over and over again, so we need more therapies. And right now, what we give lactulose is nothing more than a laxative. So we take out everything, and it is very uncomfortable for the patient. It's socially very challenging and embarrassing. So we need to get more precision as far as the microbial therapies are concerned. So what are the levels of therapy? How can we leverage the microbiota in changing the liver disease? The easiest thing is control etiology. Well, most etiologies of microbiota are not, liver disease are not really microbially driven. So if you clear the hepatitis C and the patient's microbes get better, it's not because the microbes were making the hepatitis C go wrong. It was the hepatitis C that was causing the microbes to get bad. So it is highly unlikely that the controlling of the etiology can be driven by microbiota. So if you stop drinking, is the stopping of the drinking that is making the microbiota better, not the microbiota that was making you stop drinking. The other levels would be the effect inflammatory milieu. We assume most of the inflammation in the body comes from the gut, but there could be other sources, such as the oral cavity. We could change gut microbial composition and hopefully function using things such as fecal transplant, PPIs, engineered bacteria, and dietary modification. What about changing microbial interaction with other microbes, such as fungi? Let's talk about this. Systemic and local inflammatory control. So this is the Human Microbiome Project. Remember, this is the principal component analysis. Each dot is one person's microbial change. And you can see this is GI, this is urogenital, this is skin, this is nasal. And you can see the oral microbes are very different from the GI microbes. But see, they're as abundant. Same thing happens with cirrhosis. These are the salivary microbiota in cirrhosis, and these are the fecal microbiota in cirrhosis. The salivary microbiota cluster together away from the feces, telling you they're different. So anytime people tell you that patients with cirrhosis have bad bugs, but they swallow the bad bugs, it's not really the case. The patients with cirrhosis have problems with their bad bugs because they have changes in their acid secretion because we give them too many PPI, and they also cannot secrete enough bile acids that are supposed to kill these bugs. Be that as it may, you know patients with cirrhosis have very poor dentition anyway. When they're drinking and when they're smoking, it is even worse. But normally, because of the immune dysfunction, patients with cirrhosis have a lot more periodontitis. So doing that, we actually did a trial in which we cleaned the patient's teeth and healthy controls and patients with cirrhosis. None of these patients were high MELD, none of these patients were smoking, none of these patients were actually drinking. And 30 days later, what we found, after simple dental cleaning, there was a reduction in the MELD score, there was a reduction in the WBC count, there's an improvement in endotoxin and TNF levels, and in the controls also there was an improvement in the TNF levels. In addition, there was a reduction in the salivary microbiota, the bad bugs, and also a reduction in the stool microbiota and improvement in the good bugs. This is just a proof of concept that tells you that some part of the body that we usually ignore until the patient is being listed for transplant should really be focused upon in these patients. Not just for taking care of their mouth, which is also very important, but this could also help their liver in these patients. So this is another way we can actually help this. So we came up with this oral gut hepatic axis. So cirrhosis, oral dysbiosis, and intestinal dysbiosis. Of course, with cirrhosis, you control the etiology, you prevent the decompensation, and of course, liver transplant, but that very rarely happens. In the oral cavity, you should do periodontal therapy, avoid smoking, avoid alcohol, and oral hygiene. Next time you see a patient, in addition to doing everything, just look at their mouth, and you will be scared. You know, we found it very hard to enroll patients with 20 natural teeth because many of them had very poor dentition. And we only see them when we're doing an endoscopy. When we're doing an endoscopy, just spend 2 more minutes just looking in their bug, and you'll see, it'll be horrifying. But that is all a source of inflammation that we are leaving unchecked. because we don't send them to the dentist, and many of these places don't have dental things covered. So what about microbial composition and functional change? One thing that you can do is to change the way we give PPI to these patients. In this nice study done in a mouse model in which we were collaborators, mice that were given PPI and then fed ethanol had a much higher rate of liver injury, and this was driven by enterococcus. Giving this to the humans, in compensated patients with cirrhosis, this is 1 dose of omeprazole, 40 milligrams, 14 days. And this is, the yellow is before and the red is afterwards. You can see all the yellows are clustered together, but after PPI for 14 days, they are far apart. And this ended up having a 900% increase in salivary streptococcus in the stool. It only took 1 dose of PPI 1 day for 14 days for this to happen. And streptococcus is not innocuous. It is the 3rd leading cause of SBP in our patients. So this is not something we should ignore in these patients. What about decompensated cirrhosis? In decompensated cirrhosis, in this paper that is just published, we found that people who were started on PPI had a higher increase in streptococcus and porphyromonas, which are actually oral bugs in their stool. But what was very encouraging, that even in decompensated cirrhosis, this was reversible once you took off the PPI. And we took off the PPI because these people did not need the PPI. In fact, 60% of the patients that we reviewed did not require the PPI. And PPI use was an independent factor of 30-day and 90-day readmissions in these patients. So the one thing that you can take away from this is not microbial. Go back and look at each and every patient who is on a PPI that you are seeing. If they need the PPI, please continue, because PPIs are wonderful drugs for the indications that they've been meant to. But we use them as candy. We use them for every single person. And we forget to stop them when their actual use has actually begun. It's not for forever and ever use. In most cases, it's usually for a very limited time, and then you can change it to H2RAs. What about manipulation of microbiota? We talked about fecal transplant very briefly. But what are the challenges of fecal transplant in hepatic encephalopathy? It's generally a much more advanced population than C. difficile. They are already prone to life-threatening infections, as we know, including those that are initiated from the gut. So if someone who you give a fecal transplant now develops a spontaneous bacterial peritonitis, it's impossible for us to find out whether that came from the fecal transplant or whether this was something that the patient was going to get anyway. Avoiding antibiotic post-FMT may not be feasible, and this is something that is routinely advocated in C. difficile because most of the problem with C. difficile started with antibiotics, so it's very easy to avoid them post-thing. Many of our patients are already on rifaximin and SBP prophylaxis. It becomes extremely challenging, and we don't know whether to use one donor for every single person or to use separate donors from everything. The first case report came from Canada, in which they gave this person with cirrhosis 4 fecal transplants, first one with the colonoscopy and the rest with enema, and this is what happened. The patient got better, the patient's brain function got better, it's a case report, but then he developed an infection, then they didn't do it anymore. This was the principal component analysis before, and this is what happened afterwards. You can see here, this is 3 stools from the same person. Look how different these stools are from each other. Our stools are not the same. Even though we eat the same, we do the same. If we do it separate days, they're going to have different microbial function because our microbes react to what we eat, and we certainly don't eat the same thing day in and day out. So this is what happened after the fecal transplant. So it's halfway between before and the donor. So the microbial composition shifts in between. Cirrhosis is not really a microbial disease, so you don't expect it to go all the way like C. difficile, which goes a lot towards the donor than cirrhosis. Again, this thing that we found, in which we went one step further, we did the training and we found this one donor who had all the bugs that were missing in our patients with cirrhosis. And can you guess what those bugs were? Lactospiraceae and Ruminococcus. The 2 bugs that make short-chain fatty acids were the ones that were missing in the patients with cirrhosis and hepatic encephalopathy, but were present in healthy controls. So we chose the one stool sample from the one control who had the highest relative abundance of these bugs, and we gave them with the antibiotics, as was pointed out, and we followed these patients for 150 days. And again, there was reduced hospitalization, cognition, HE episodes, and more importantly, as we're going to talk about in the few slides, there was also a functional improvement. The antibiotics just came in and destroyed everything. That's what they were supposed to do, but they destroyed everything. They reduced the diversity to shambles. They also made the bile acid and short-chain fatty acids really bad. And this is what happens. So in microbial transplant that was done in animal models, using bacterial flora that does not make ammonia, there is a group of bugs called the altered Shadler's flora that does not have any ammoniagenic molecules. They found that this reduced the ammonia production and improved the mortality of the mice who were given this fecal transplant. What about humans? There was an improvement in brain function in these patients who received the fecal microbial transplant compared to standard of care, both on the app as well as the psychometric hepatic encephalopathy score. This tells you there's a functional correlate also. So this is short chain fatty acids. The green are the people who received the fecal transplant. The orange are the people who did not receive a fecal transplant. And you can see the reds are throughout. This is acetate, this is propionate, and this is butyrate. This is baseline, this is day 5, and this is day 20. Day 5 is when they were given the antibiotics. As you can see, at the end of day 5, there is absolutely zero short chain fatty acid production because antibiotics supposed to destroy everything, and they did. They even destroyed the good bugs. So everything was gone. But when the fecal transplant was given, this recovered. So which tells you that fecal transplant could have things beyond hepatic encephalopathy. In our patient who get multiple doses of antibiotics, who have it's impossible to believe that they will recover these functions themselves. This could also be another way. Same thing with bile acids. Everything got destroyed with antibiotics and came back with a fecal transplant. So fecal transplant in this group was able to not only improve their brain function, it was also able to restore everything that those 5 days of antibiotics had destroyed. And very interesting thing that we can easily apply to our populations is changing the diet. In this study that we had done, we took controls, compensated and decompensated patients from the United States as well as Turkey. They were kind of age matched as much as possible. And we found the diversity, it's very good teaching that the more diverse your population is, the better off you are. But here we found in patients in Turkey, the diversity was the same between controls, compensated and decompensated patients with cirrhosis. Whereas the ones in USA behaved like they were supposed to. And why is that? Because the Turkish patients were drinking fermented milk or milk that had probiotics in it as part of their daily life diet every day. And this was able to supersede the effect of cirrhosis on their microbial diversity, and moreover was associated with the protection from hospitalization. So an importance of diet in this may be very important, and also the control for diet and possibly giving a Mediterranean diet could help in these patients with cirrhosis. What about engineering probiotic bacteria? In this, they basically have a bacteria that sucks up the ammonia. It's now in phase 2 clinical trials. Instead of the bacteria actually making ammonia, this one it sucks up the ammonia and actually makes arginine in some. Then you have microbial interactions. In this study, which I'm not going to go in details, if you fed the mice alcohol, there were high fungi. And in this other study, the fungal diversity and the bacterial diversity were clearly linked with each other. And you can see these are the healthy controls up top. The red are the compensated cirrhosis, and the green are the decompensated cirrhosis. The fungi and the bacteria were clearly related to each other. And what's more important is the infected inpatients or outpatients and antibiotics that had the lowest fungal diversity. Basically, a healthy fungal diversity was replaced with candida. It was candida everywhere, and you can see that's why candida is one of the #1 reasons for infections in our patients with cirrhosis, because we use so many antibiotics and we have no way of bringing it back. So the fundamental question here is, are cirrhosis and chronic liver disease microbial diseases? In other words, if you tell a patient who is drinking that you don't need to stop drinking, but I'll fix your microbes and your liver disease will get better, is that actually going to make a difference? The answer is no. Liver cirrhosis requires liver injury, and you have to fix the liver injury first. You can't just fix the microbes and expect the liver injury to fix itself. Microbes are important, but not necessary. So if you took germ-free mice and you gave them healthy human stool, non-drinking cirrhotic stool, non-drinking cirrhotic with HE, actively drinking non-cirrhotic, and actively drinking human, all of them cause systemic inflammation, which is to be expected. This mouse has never seen any bugs. So any bugs you put in, they'll get inflamed. All of them did cause inflammation, but the cirrhosis and translocation only happened if the mouse was being fed alcohol or some other liver injury was happening. which means things need to be together. If they are separate, is not enough to cause liver injury. So bugs are important, but not necessary. So conclusions. Microbial changes are an integral part of the altered gut-liver axis in cirrhosis and pre-cirrhotic liver disease. They are complicit, but not necessarily causative of liver injury without the direct liver injury also. Microbial treatment in liver disease has to be accompanied by treatment of the liver disease. Current therapies can be improved by precision changes in microbiota, focus on the oral cavity, interactions between bacteria, host, and fungi, and newer therapies focusing on bacterial function are needed. Thank you.
Muchas gracias, doctor Bajaj. Estamos justo en el tiempo de dar por concluida la simposia y creo que tenemos la sesión de negocios. Muchas gracias.
Asistentes.
Qué padre, ¿no? ¿Cómo aprendes?
Les tomé, luego se las mando, sí les tomé ahorita.